I think what the Gates Foundation and the Johns Hopkins Public School of Health are doing today in having a day-long conference on how to improve advocacy for public health is absolutely the right step to take. Because first of all, there is extensive social science evidence on health and health disparities. However, there is not enough advocacy that ties the research to policy, law, and most important, real changes in people's lives. So for there to be institute here at Johns Hopkins on public health advocacy to address not only how to do that, but actually to do it, is those are exactly the right steps to be taken. I am a civil rights attorney and an advocate, and as lawyers we have to prove what we all know is true. So we have analyzed extensively the evidence of health disparities based on race, color, or national origin. And what we find is the evidence is pervasive and persistent over time. Nevertheless, the social science evidence stops with, here are the disparities, and that's it, instead of going the next step and the academics saying, and these are the recommendations we make under law to change policy, to change people's lives. And I think there's this phobia that if an academic actually makes a recommendation, he or she will taint his or her objectivity, and we simply have to overcome that. In part, academics are, pardon me, but they're terrible writers. Social scientists are terrible writers. You know, when I read an article and it starts with the R factor and the P variable and all that stuff, my eyes glaze over, and I turn it over to one of our experts and say, what does this mean in plain English? And having said that, you know, social scientists, experts we work with always tell us, Robert, you have to stop talking in legalese. So I think part of the problem is they're different languages. Social scientists speak in one language, attorneys speak in another language, and we have to find common ways of communicating not only with each other, but with people, real people. Community-based participatory research is one way of doing that, listening to real people about what their concerns are, engaging, educating, and empowering them. All of that is entailed within advocacy. And advocacy, for example, from our perspective, includes academics making the leap from their research to real recommendations and more importantly, real change. It also includes organizing, which we define as finding out what people want and then finding collective ways of getting it. And third, I am an attorney. I'm a litigator. I'm a recovering litigator. We also use law to translate research into change. And law does not have to mean litigation. Many people, when they think of attorneys, especially in the health context, think, oh yeah, my friend had a back problem and it went bad, so they sued the doctors, and so everybody hates the lawyers now. That's not all that legal advocacy means. It also means planning, and it means broader changes in society. The public health community actually has a rich history of addressing health disparities, starting in the 1960s when, with federal funding required that hospitals and health services be segregated. Blacks only, whites only, for example. And attorneys working with health experts took a case through the courts, and the court held that separate medical facilities are inherently unequal and unconstitutional, applying the principle of Brown v. Board of Education. Later, in 1964, the Civil Rights Act of 1964 was enacted. The Justice Department went to mostly southern health facilities and said, if you want federal funding under the Civil Rights Act of 1964, you have to meet non-discrimination requirements. And that led to real improvement in the outcomes, health outcomes throughout the South. There is a rich history and tradition of doctors and public health experts and practitioners working arm in arm with civil rights attorneys to achieve health justice for all. but that seems to have been forgotten or ignored in more recent years. We find hope in the fact that the Affordable Care Act has a provision explicitly addressing health discrimination. That is the most recent statement by Congress that discrimination persists in the health field and has to be addressed and eliminated. So it is a question, again, through an institute like one here at Johns Hopkins, of reviving that history and teaching not only the students but even the faculty that advocacy matters. Advocacy can make real improvement in people's lives. Is advocacy a science? It is more of an art, but certainly you can study art systematically. You need to study advocacy systematically and find out what are the best practices. And we know what some of those best practices are. One is the civil rights movement, as I said, which included, first of all, attorneys going in the court, advocating change. Thurgood Marshall and the NAACP Legal Defense Fund pioneered the 20 or 30 year strategy that led to Brown v. Board of Education, which held that separate schools are inherently unequal. Second, courageous courts. The U.S. Supreme Court, the Warren Court, struck down apartheid, legal apartheid in the U.S. Third, it was also the movement in the streets, Martin Luther King and others, the March on Washington, for example. Fourth, that led directly to the passage of the Civil Rights Act of 1964 by Congress. Fifth, the President of the United States, Lyndon Johnson, a Southern president, broke the filibuster to get the Civil Rights Act passed in '64. Sixth is the federal government then enforced the Civil Rights Act of '64, working with attorneys, both in and out of court, as I say, by going to Southern schools and saying, if you want federal funding, you have to desegregate the schools. Going to the health facilities, if you want federal funding, you have to desegregate health care. And then finally, it was the will of the people. Lyndon Johnson in the '64 election, running against Barry Goldwater, who would have dismantled the civil rights protections. Lyndon Johnson won by a landslide. And those are central lessons for how to do things now. Tobacco litigation and advocacy is another important lesson. The effect that Mothers Against Drunk Driving have had on reducing drunk driving, that these are all movements. They're not just, and so the movements are part of advocacy, right, but it's also the lawyering, including access to justice through the courts, and absolutely gathering the evidence, but translating that evidence into change.
So public health at its core is about social change. A lot of the great advances that we've had in our society due to health have resulted from a combination of the development of science on a particular issue and then the advocacy to, in fact, create change. So one of the places that we've fallen off in public health is we really haven't paid as much attention to advocacy currently as we did way back in the origins of public health. Public health and social work, for example, historically have a lot of similarities because they were really about social change, changing the conditions in which people live and work. And it was by changing those conditions that we started seeing increases in life expectancy. This isn't very much of a distinction that needs to be made. Do you just focus on changing people's behavior, or do you focus on those policies that limit the range of behaviors they need to, that limit the range of behaviors that people can select from? And what public health at its best is about is creating the conditions in which people can be healthy, and that means affecting the policies that either restrict or limit the range of choices people have. Advocacy isn't about science. It's like political scientists think that politics is about science, and they know it isn't, but it's a useful way to think about it. What we know, for example, one of the major findings in public health over the years is that social inequality leads to health inequality. So what does that tell us? We have a science that is reinforcing this idea The challenge, though, is then how do we develop advocacy programs to reduce social inequality as a way of dealing with this health inequality? There's no particular formula that we can apply to do that because that's the process of social change. So it takes lots of different perspectives. It takes lots of different professions. It takes a long time because we're talking about changing the conditions in which people live. So advocacy really is what we need to do when we don't really know what to do. In other words, there's a leap of faith. What we're trying to do is enact a vision of what the healthiest possible society would look like. We have an idea of what the health variables are there, but we don't really have a good sense of how we create the change so that that becomes a reality. So if there were a science to doing this, we would have already done it. The fact is we're learning it as we go along, and we're looking for good examples. And there are good examples, but these examples don't provide that specificity of scientific certainty that allow us just to develop a template or a formula that others can use. Part of the training for scientists and researchers needs to focus on what do you do when you finish the research. So we spend collectively as a society billions of dollars of taxpayer money funding research. And this research has developed enormous insights into every aspect of our lives. Most of it, though, is completed and just sits on shelves. We have a fiscal responsibility, a moral responsibility, a social responsibility to take that knowledge that was created with collective funds and translate that into public benefit. Advocacy is what we need to do to make that translation. And we're here today learning about what are some of the ways that might happen, but we're a long way from knowing any specific formula to create that. Senator Cardin said this morning, it's not about fewer resources going into research. We need a lot more resources into research, but we also need more resources into advocacy. So the idea isn't taking sort of a narrow perspective and saying it's an either-or question here. We need to look at other areas of our society where we're spending lots of money with very little return. And what we need to do is rethink whether the way we budget as a nation is really helping us attain the goals we have as a society. And the answer is no. For example, I've been in public health for 40 years. This next generation will be less wealthy, less healthy, and less well-educated than the previous generation for the first time in American history. This reflects a very poor idea of how we spend money to create a healthy, stable society. So we need to look society-wide. It's just not a question of, in public health, do we need more money or less money for research versus advocacy? This needs to be a higher social priority overall, and it needs to be reflected in the budget. There are examples of advocates who run and get elected to office at the state, local, and federal level. And I think this is a part of it. But we don't need those specific people. What we need are a greater dissemination of the values that advocates have that represent a progressive vision of what American society could be. It really says that there is a promise of America that we have. And it's a promise of America rooted, in a sense, in the core of public health. And how can we use advocacy to realize that promise of America that we all believe in?
It is difficult to define what works in advocacy in a way that would meet the scientific standards of an institution like Johns Hopkins University Bloomberg School of Public Health, because the expectations in the world of public health, the expectations for quality of evidence are appropriately very high. And it is extremely difficult, if not often impossible, to have the same level of certainty, the same level of evidence involved in advocacy work. But should it be an arrow in the public health quiver? Absolutely. And I think we heard today repeatedly from Senator Cardin, who has received a lot of advocacy in his time. from the dean, talking about the school's record and its contributions that have combined advocacy and evidence in very effective ways. I think we know that advocacy already is a part of the public health armament, and doing it, or seeking at least to do it in a more systematic way, makes wonderful sense for this institution. There is a lot of work out there being done in engaging members of the public to become more effective citizen advocates. We heard actually at my institution, at the Aspen Institute, we heard just last week from Sam Daly Harris, who helped to organize Results, a very effective citizen lobbying network on global poverty, and who since went on to organize a global movement, he would call it, to promote access to microfinance for low-income women in the developing world. And Sam's basic message to our seminar was, there are skills that can be taught to American citizens to help them be more effective advocates to their elected officials in particular. And so there are a body of skills that, yes, can be conveyed. However, what you can't train is passion. And I think the passion that advocates bring to an issue is either there or it isn't. Right. And that's the part that people have to bring with them to the task. There will need to be interactions between those academic experts and citizen advocates, and it can go in both directions. Some of what we were talking about earlier today underscores that sometimes it's the research that gives rise to an advocacy effort, because it suddenly becomes clear, as we heard earlier today, that secondhand smoke actually is harmful to me and harmful to my children. And that research, when it became available, fed advocacy by citizen groups. So in that instance, the research came first. Some of the folks that I work with in advocacy campaigns have the idea that, if we had some research to back this up, we'd be much more effective. And then they will go out and, in effect, commission research or ask an academic institution, would you look into this? So it can move in both ways. That is, sometimes public health researchers who have created the body of evidence are not terribly good at translating it into terms that a larger public can hear. And if they're smart about it, they will realize, I need some citizen mobilization to back this up. Is that the job of the university to make that mobilization happen? Probably not. But a smart expert who believes passionately in getting that information acted on in the public policy arena will figure out a way to connect with advocates who can take that research and move it, and to encourage and incentivize its research staff to do that, and not to just keep it in-house, not to keep it, not only to seek the conventional measures of academic success, as in refereed journals publishing and publishing one's work, but also to say, and another measure of success is how effectively did you take that research and where relevant, and turn it into the basis for larger advocacy activity. In fact, I think a really interesting research question for Johns Hopkins and for this institute is to really delve deeply into the question of the interaction between law and attitudes and behavior. Because in our experience, we sometimes see that legal change, banning something, will actually change behavior, as long as it's enforced and enforced appropriately. Other times we find attitudes just don't change. People still don't wear their helmets, right? Even though they're legally obliged to do so. So what is it and in other instances, it would appear that it's the attitudinal change that reaches a point where enough people say, well, I'm going to make this change, and there ought to be a law. So what is it, under what circumstances do attitudes drive legal change and behaviors? And in what instances does the behavioral change precipitate a legal change that is just essentially catching up with what the public's already doing. And I think this is an institution that already focuses on attitudes and behavior and understanding social norms and individual norms. And there's a lot of gray, at least there's certainly a lot of gray in my understanding of how social norms and individual norms interact with legal change. And I think that's an area that's, I think that's an area that would be ripe for further research.
So I work in advocacy, and I also work on research development. I work for AMFAR, which is the Foundation for AIDS Research, and we've contributed a little bit more than $360 million in investments to HIV research across the globe since the beginning of our organization. And of course, we find ourselves existing at the nexus between, innovative research developments and how they actually inform public policy decision making. And I work in the public policy office, so I'm at the nexus of trying to make those research findings impact policy practice. Part of the nature of advocacy is that it's ever changing. There's not one model, I think, that works for everybody or for all contexts. And I think as more information gets out there about the issue that I work on, which is HIV, and the more tools that become available, I find that I'm working with different individuals and approaching some of the same issues and tasks in a different way with a different strategy. And a lot of that of late has, of course, taken on a very incredible lens into figuring out how to engage the public health workforce in a far more meaningful and in a tangible way. Not only because we've had important scientific developments around the role of antiretroviral therapy in both improving the lifespan as well as health outcomes among people with HIV, but we have this incredible new innovation in understanding that antiretroviral therapy also has an important role to play in prevention of onward disease transmission in the global and the domestic epidemic. So I've traditionally been working a lot with clinicians who have, for the longest period of time, been working on the clinical environment and how to do a better job of providing care to people with HIV that are in the clinical system. But now we figured out that we have to go broader, and I want to figure out how we can empower more public health scientists to help us make the case for a lot of the different strategies, community system strengthening and health system strengthening that needs to go on in the South, in the rural South, as much as it needs to go on in sub-Saharan Africa to empower more of the advocacy that's going to get the kinds of decisions made that we'll need to make progress. There's a role for advocacy in all professions that are doing work because, of course, policies shape how we live our lives and do everything that we do in our existence. So one of the things that I could immediately see Johns Hopkins doing, and you already do a great job of public policy education within the public health program here at the institution, but certainly your efforts to really kind of push public health scientists out there to actually be present in communities and see how a lot of the research developments either have impact or don't impact, I think is hugely useful to the advocacy field down the line, because we find that when individuals get in environments and they bang their head against the wall, they recognize finally what the important role of advocacy is. And as part of our challenge in the way that we've designed the field, right? The incentive for public health scientists is to get published. It's not necessarily to make sure that their publications actually impact things down the road. So I think, with the respectability of an institution like, and the authority of an institution like Johns Hopkins, you can also impact the field of public health practice down the line. At AMFAR, we've been quite good at showing really how you can make a business model out of making research outcomes real for people in a lot of different contexts. I think a lot of people are excited about people that actually want to make the work that they fund have impact. So a lot of people that want to invest in cancer research, but more people want to invest in a cure. And I think, the more that we're able to show people that you're not just investing in understanding how the HIV virus moves through the human system, you're saving lives and you're preventing newborn babies and parents of children that need to grow and be cared for long into the future, you're actually giving them hope and a future. And once you can actually make those research articles really real in the lived experiences of people around the world, people want to invest more. I'd just like to encourage Johns Hopkins to keep doing the work and to hopefully give the tools and assets that you have to people broader than just the institution. I think there's a community out there as well that is ready and willing to engage in advocacy that would appreciate a lot of what you can offer.
There is an important gap that still exists. The gap isn't research in how to do advocacy. The gap is in transmitting the knowledge that exists to advocates and potential advocates around the globe. What we all find is that what we take for granted in terms of knowledge about how to conduct a campaign to either get government or major organizations to engage in smart, evidence-based tobacco control policy isn't common knowledge around the globe. So it's not unusual as you travel around to find passionate, knowledgeable, skilled individuals and organizations who don't understand how to move their government forward or how to work with the media or how to build political coalitions. It's more than just transmitting the knowledge to advocacy efforts, because far too few people realize that there is a science to doing advocacy, but we have the science base. However, often people don't treat advocacy as something that there is a science knowledge base about how to go about it. An institution like Johns Hopkins could both give credibility to people appreciating that there is a science base, there is something to learn, then transmitting what it is, and then equally as important, training people around the globe to do it in ways that are appropriate for their political system and their culture. It's one of the biggest hurdles to progress in tobacco control in many countries. There are knowledgeable, passionate individuals and organizations, but they don't have a tradition of working to persuade their government to adopt population-based solutions. Learning how to do that in a way appropriate for their culture that takes advantage of what we know is one of the biggest gaps in public health in tobacco, but not just tobacco. You know, one of the hardest things in working with public health professionals is to get them to understand that the solution to many public health problems, tobacco is just one of them, are political and social, not medical and clinical. So if you're going to adopt population-based solutions, and those are increasingly the most important solutions for all of the risk factors related to non-communicable diseases and other major public health problems, you have to understand the political system and how political change takes place, and therefore you have to understand how to do political issue-oriented campaigns. That's not a skill that's widely understood throughout the world. Political change is always a challenge, particularly when you have an opposition, and we in tobacco always have an opposition. But it doesn't matter the political system. The challenge to an advocate is to figure out, given who is in power, what they believe and what motivates them, how do you develop your public health argument in a way that will persuade them? And we have seen across the globe that you're capable of doing it in open, thriving democracies, but you're also capable of doing it in countries where government officials aren't responsive to the public in the same way. So we've seen a good deal of progress in the last 4 or 5 years in countries like Russia or Vietnam that you don't think of as countries where the governments are responsive to public concerns and public pressure. The reason they're successful is in fact that we and Hopkins and others have been able to work with advocates in those countries, learn from them about their system, learn from them about the unique nature of decision making in their country, and transmit to them the skills and knowledge base about how to take that knowledge to develop comprehensive, effective campaigns appropriate for their country. We are trying to document it because it is very important, I think, to do so for a lot of different reasons. In the end, outside donors, outside advocates can serve as a catalyst, but unless you build capacity within those countries, then we won't see long-term change. Equally as important is that there are misconceptions that you can't do the kind of advocacy necessary to bring about change in certain political systems. That's not true if you do it right. One of the keys to good advocacy is always being a good listener, asking the right questions, and adopting your strategies to the local culture, political system, and interests. Having said that, once you've done that, then it's critical to understand that a key campaign involves, identifying the issue with solid science, identifying a solution with solid science, and doing the political mapping to understand how decisions are made in that country and to what political officials respond to in that country. When you've done that, then you have to work with the local culture to build the kind of pressure, public support, media attention that's necessary. You can do that in whether or not it's an open and thriving democracy with a free media, or if you're careful, you can do it in a closed country where the government controls the media. Indonesia is a country that is one of the most challenging countries. It is probably the most backward nation in the globe on tobacco control at the moment. The central government has not been responsive. The media, however, has been very responsive, and so many of us working with the media in Indonesia have changed the public discussion and public debate. And what we have seen there is, while we have not seen major steps forward at the national level, we have seen significant steps forward in a number of major cities in Indonesia, and that can serve as a building block for long-term change. You have to seek out victories where they're achievable and understand what the building blocks for bigger achievement will be long-term. You know, public health isn't for the faint of heart. It isn't for those people who have a short attention span. Whether you're in the United States or outside, you know, we've had enormous victories in Russia that looked like it happened instantly, but took 4 years of solid work behind it. In the United States, it took us over a decade to get our Congress to pass legislation giving the U.S. Food and Drug Administration authority over tobacco. So if you're going to succeed, you've got to act as if the problem is urgent, but be prepared to be in it for the long haul. There's a critical question that people always start out, and that is, can you transmit knowledge about how to do advocacy? And my answer is, not only can you, but if public health people are going to be successful, they have to. Prepare to get your hands dirty. If you're not willing to get your hands dirty, don't call yourself a public health leader, because you won't succeed.